And it's always tell you there, now you can just close that. And it'll always use that little flash. And it lets them know, them know as well. Well, I'll hang out back here in the back of so everybody can.
Okay, so we're not officially started yet. I'm waiting for our June to join. She should be here. Oh, okay. A sign-in sheet, and we found who we think is registered for this course. If your name's not here, just write it in on the third page. I believe there's 3 pages of names. So let me start from the bottom up. GA for this course, Yang Chen. She just joined us. Yang is a doctoral candidate in epidemiology, and if you'd like to say a few words of how you plan to administer this course.
Okay, hello everyone. My name is Yang Chen. I'm third-year DRP student for IP, and I'm teaching assistant for this class for this semester. And if you have any questions for this class, for your homework, access, or exam, you also can send an email to me. Or if you want to talk with me, you can just come to my office. My office is also in this Lamp Hall 146, Department of Biostatistics and Epidemiology. I'm in the room B. But please make an appointment with me by email firstly. And the online student, if you also want to talk with me by phone, you please send me an email firstly and make an appointment. I will respond with my phone number and make sure of your appointment. And so I will try my best to help you to finish this class. And I also hope you can enjoy this class.
Thanks. And I think next week we're going to start with.
Okay, yes. Next week I think I will start to introduce software. It's a necessary software for the IP. It's called Epidemiology, and I will introduce about this software and how to use this software. But I think we will do some access in the week 4 to use this software. Please prepare a laptop in the week 4. We need a laptop. And if you don't have a laptop, please send the email to me. I will prepare a laptop for you.
Okay, and so we'll continue to remind you of things that you need as you go through the course. For those that also don't have a laptop, we will most likely travel to another classroom down the hall. So my name is Claudia Kozinetz, and I'm your instructor for, this is Epidemiology 5400. We refer to it as Epi1, and so as they say on the airplane, if this is not your destination, you can quietly leave the room, but I think you're all here. This is a relatively large class for us in the College of Public Health, and so please provide us with feedback if the room isn't working out for you or you can't hear us. But we will try to, use distinct loud voices, and that means you also, because we are all going to learn from each other during this course. As you look around the room, it's a very diverse group of individuals here, and that's what's so exciting. At least for me, that was the most exciting thing about my graduate studies were the individuals that I had the opportunity to interact with. The faculty, the staff, but more importantly, the students. You're all here because you chose to be here, and congratulations that you are here. I hope you're beginning to understand that graduate education is quite different than undergraduate education. We aren't going to be perhaps holding your hand at all, and want you to steer your own course, learn about the college, learn about the university, and take advantage of what is here. There is so much here at ETSU. As you know, the College of Public Health is part of an academic health science center. So not only do we have public health, we have the College of Medicine, the College of Nursing, the College of Pharmacy, and the College of Clinical and Rehab Health Sciences. And so many of the students, faculty, and staff have collaborative projects among those colleges, and that allows us to take a multidisciplinary look at public health issues, with epidemiology being only one component. Certainly a very important component, but just one component. Now, as you can see, I've got an MPH in epidemiology, and I received my MPH from the Graduate School of Public Health, University of Pittsburgh. And I did that immediately out of undergraduate school with a major in biology. And then after finishing my MPH, even though I really wanted to stay where I was comfortable, where my colleagues were, where I absolutely loved the program, I thought that it would be helpful to get a different view or a vision of epidemiology. And I'll use an example of the Supreme Court justices. They're all lawyers. They all know the Constitution very well, but they have different views about the issues that are coming before them. They vote. Sometimes it's, you know, how many against how many. They don't necessarily agree. And so that's the same thing with epidemiologists. I don't necessarily agree with all my epidemiologic colleagues. And that is exciting because we can have discussions, learn from each other. It's okay to have a different opinion, a different approach, as long as you're able to justify your decisions and your approach. And so we are in Epidemiology 1, the basics of epidemiology, and we are providing you with an approach for epidemiology. It is an approach that is led by Leon Gordon. The text for the course, Epidemiology. It is our cookbook for the semester. As you've noticed from the syllabus, we are going through chapter by chapter by chapter, okay? And one of the reasons why we do this is many of you are in the MPH program. And in order to progress through the MPH program, you need to take a series of core courses. This is one of them. And then after you take your core courses, you take an MPH comprehensive exam. And the exam is based on the 5 core courses. And so we use a text. We go through each chapter of this text. Once you master this text, you will master the epidemiology portion of your comp. And so we are here to make sure that you are successful on the epidemiology portion of your comp. There are many epidemiology texts, basic epidemiology texts, fairly similar, but the way in which they are presented might be a different approach. So the outline of this course is found in the course syllabus, and that was on D2L. And I know probably all of you have been into D2L already. You've begun to introduce yourself to your colleagues, and that was great. I learned an awful lot about you. The course syllabus outlines the competencies and learning objectives that instructors use to develop a course to make sure that you are competent in basic epidemiology. All of your weeks are outlined, the activities that will be included, the topics that will be discussed, the required readings. Once again, the required readings is basically your text for this semester. The times of the exams are noted. We have exam 1 in week 8 on October 14th. We will be using a different room for that exam. We will be in the computer lab, which I think is either 132 or 136 down the hall, and you will be randomly divided in 2 groups. Group A will come to the room at 1 o'clock and take your exam on a computer through D2L. And then Group B will come halfway through our time to take your exam at that point. And then a note for those online students, exams must be taken at a testing center. Testing centers employ proctors, and there are instructions in the syllabus for providing the information that's needed regarding your proctor and your testing center. Also described is the discussion board. There are 2 discussion topics listed in week 1 of the syllabus, and then we will have additional discussion board topics weeks 4, 7, 10, and 13. Also within D2L are quizzes. There is a quiz for each week of study. The quizzes are not graded, but we do ask that you take them. They're short quizzes. Are they timed out in 15 minutes? If you don't enter all of your answers within 15 minutes, you'll be bounced out of the quiz. But they're helpful, and they reinforce that you know the materials for that week. Also within D2L is some information on how to critique a journal article. You will have, you'll be required to critique 2 journal articles during the course. We've got in the syllabus information on attendance policy, the grading scale, and other ETSU policies that will affect you while you are a student here. Now, you saw at the beginning of the course, individual from Office of Information Technology was setting up WebEx. WebEx is used to record the sessions, each of the sessions that we have on Wednesdays, starting at 1 p.m. You also will have access to the recordings through D2L, and after this session is complete, I go back to my office. I'll receive an email that will give me a URL of the recording, and I will place that address onto the D2L site. And so you can watch this as many times as you wish.
Will those recordings be available like next semester as well when we're preparing for our comprehensive exam?
Excellent question. They are not. When this semester ends, the classes are shut down, and so it is advised that you make a folder and copy all of your course materials to that folder so that you can use the materials in preparation for this exam. Thank you very much for that question. For those online, I was just asked if the materials in D2L are available after this semester. They are not. D2L gets shut down at the end of the semester, so please make a copy of all the materials that are made available to you on the D2L site. As I'm trying to, oh, there I go. Okay, all right. Quick overview of, yes?
Actually, you might cover this in a moment, but I was just looking at the discussion list, and this first week I was a little confused if, like, the second, there's like two, there's introduce yourself, and then there's like a little discussion about historical trends. I was confused if in class there's stuff to discuss there or.
Right. You can. I think I prefaced it with the on-site students discuss this case study during class. I wanted the online students to have the opportunity to discuss it also. If you want to join in, yes, you can. Okay. And so we hope that you join in on the discussions. Once again, the discussions are not part of your grade, but I think it's participation in those discussion boards that make things yet a little bit more interesting. They add a notch above what you are required to do, but also allows you to, once again, learn from your colleagues. But thank you for that question. So generally, D2L is divided into the course home. When you initially open D2L, you're going to see any news items that have been posted so far. I believe there's been a welcome to the course, and I also indicated that the course syllabus had been updated. The most current version is version 4 with a date of August 25th. It also, that section of D2L provides you with the WebEx connection information. If at any time you cannot make it to class, you can connect through WebEx and join us synchronously, or you can join us asynchronously. I suggest that you try not to do that. You made the choice of being an on-ground student, and I hope that you continue to do so. But, you know, things happen, right? And so nice to have options when you need them. And then the calendar is also on the course home. The content module gives you a general tab and then all the weeks of the course. It basically follows your syllabus. Within the general tab, that's where you find the course syllabus document and information on journal article critique. I believe there's a document and also a PowerPoint file. And then you have week 1 through week 16. Can you makes it sound like this is going on forever and ever, 16 weeks of this. But let me tell you, it's going to go by quickly. And so the classes and the required readings and the slides, you will find, okay, so for each week, you should be reading 1 or 2 assigned chapters. And then you will find on D2L a PowerPoint that is called Week 1 lecture slides, Week 2 lecture slides, okay? Those slides primarily mirror the chapters. They point out the important aspects of each of the chapters. I am not going to use that PowerPoint lecture slide to show you slide after slide and just repeat what is on the slide, okay? That is a resource for you, a tool for you, and you can use it however works best for you. And then your exercises are also in that tab. Exercises, you have more than 1 week to work on them. Your first exercise is posted on D2L, and it is a case study. It's going to be similar, but more in depth to the activity that we'll do later on today. I do want to emphasize that you do not need to complete Part 5 and Part 6 of this exercise. Read through it, and you can complete it if you would like to, but you are not required to do so because it is about environmental studies and water investigation and just not exactly related to the materials that we want you to focus in on for this course. The communication tab in D2L, that's where you find your discussion board. And then in the evaluation tab, under assessments, you'll find your quizzes 1 through 13. That's very unlucky. We probably should only have 12 quizzes, you know. And then your exercise will be placed in a Dropbox, and that is found in the evaluation tool also. Okay. We have been asked as instructors to help continue to make this or maintain this as a safe environment for everyone. And so I did pass out earlier. Some of you may not have a copy of emergency procedures that we follow here at ETSU. If we are, okay, so I just did the first thing that I'm not supposed to do. I don't have my cell phone with me. We call 911, or I have programmed in my cell phone that I do not have with me to call ETSU Public Safety. Become familiar with the building and learn how to quickly exit the building if you need to do so. If we hear fire alarms, we always respond to them and we exit them in an orderly fashion. And, you know, just have these, read them over. And then you should also sign up for the ETSU alerts. What are they called? I think it says it. The gold alert. Yes. That's very, very, very helpful. Okay, now I am standing in front of the distinguished learners. Okay, and I want to learn more about you, what you're interested in, and so let's think about some skills necessary to be an effective epidemiologist or public health worker. At some point in your life, you're going to have a job interview. And you are going to be required to communicate with your potential boss or supervisor why you should be selected for the job. You need to be clear. You need to provide information that's useful for that supervisor to use to understand why you are the best candidate in the pool that's applying for the job. Communication skills are so important. You need to learn how to be comfortable in a small group, in a larger group, expressing what you're interested in. What's your research topic? What's your elevator spiel for demonstrating what your public health passion is? On the flip side, another important skill is listening. Okay, so we're all going to listen to everyone today because everything that you have to say is important for us. We want to begin to know you as colleagues when we pass you in the hall. At least we'll know how to start a conversation with you because we'll know maybe why you're here, if you've had involvement with epidemiology in the past, or perhaps what your expectations are of this course. There are a number of things that you can inform us of today. And so I am going to start with an icebreaker, and it's going to be Daniel in the back of the room, who is one of our guest lecturers. Daniel is also a DRPH candidate in epidemiology, and he came to sit in and sort of see how I was going to approach Epidemiology 1, because for some reason, instructors don't like teaching Epidemiology 1, but let me look at our schedule. Daniel is scheduled to be our instructor for week 5 on September 23rd, and then he will lecture again week 12, November 11th. The first time he's doing me a favor because I'm going to be out of town, and the second time is related to some of his research interests. So Daniel, go ahead, introduce yourself.
I think I've already done introduction last Monday, isn't it? I'm Daniel Wusu. I'm a doctorate student in epidemiology. My interest is more in research and then public health advocacy as well. At the moment, I'm working on tobacco because I've realized that it is becoming a major issue in the developing world. And cancer and other non-communicable diseases are also rising. So we need a lot of people to do some sort of research and also be able to help in policy development. So that is what I'm working on. My professional interest aside the research is also to be an academic. So I decided to have some experience talking to you and then learning also from you. So basically that is about unless someone wants to do. Thank you.
Thank you, Daniel. Okay, so now we'll just start going from the back to the front.
Hi, everybody. My name is Tom. I just graduated last May with my bachelor's degree in chemistry, and I was hoping to go to med school in the future. And I think that having a graduate education in healthcare administration and epidemiology will help me better adapt to the change that's happening in the healthcare system nowadays. And my only past experience with epidemiology is through studying immunology, learning about diseases and treatments on the biological scale. And I'm hoping that I'm hoping in the future I will be able to get to learn more about its effects on large communities and populations.
I'm Elaine. I got my bachelor's in microbiology.
First and last name.
Oh,
Thank
Elaine
you.
Loudermilk.
Thank you.
So yeah, I went here and got my undergrad in health sciences, microbiology. I became interested in epidemiology when I couldn't decide between medical school or epidemiology. So now I'm going to try to do both. Primarily interested in infectious diseases. I draw blood at the hospital, and so that kind of was like a big push for me to actually go to grad school because I'm surrounded by a lot of people who are sick, and it just makes me wonder why and what can we do to make them less sick. So kind of what I'm hoping for is to figure out with epidemiology how to do that, and then hopefully in medical school just hopefully I'll be a better doctor because of it. Hi, I'm Sonita. Sonita Sam. I'm from Bangladesh, and I've completed my bachelor's in medicine. And before coming here, I was working on a microbiology lab, and the most important reason I became interested in public health or epidemiology because public health is a subject that works on like community, not individual. So though I'm a doctor in Bangladesh, so I do clinical practice. So I think public health is a better thing that it concentrates on the whole community rather than a single person. That's why I'm more interested in public health. So that is why I'm here. Hi everyone, I'm Jarvi Choksi. I live in Johnson State for now, but I did my Bachelor of Dental Surgery from India, and I introduced myself to epidemiology in my dental school years, and then I studied epidemiology of renal dental disorders as well, and then I put into practice during my clinical practice in India. And I also did research here with Dr. Moore. He's a psychiatrist at ETSU, and I became more interested in biostatistics since I started working with him in biostatistical data analysis of various disorders regarding mental health. So that's why I'm in Masters of Public Health. Hello everyone, I'm Claudia. I'm from Nepal. I've done my bachelor's in public health itself from Nepal, and in my bachelor's I was taught two courses in epidemiology, basic epidemiology and applied epidemiology. During this period was when I got interested in epidemiology. That's why I chose an elective in my final year for epidemiology too. The main reason I was interested was because during the course of study, I came to know that there are very less people in Nepal who are actually skilled to undertake research. So maybe that's the reason why the public health status is low in Nepal. So that's why I wanted to do epidemiology. After my bachelor's also, I was involved in research activities for a year, and then after I am here as well.
Hi, my name is Haisen Wani. I'm originally from Rwanda. I haven't had any experience with epidemiology, to be honest, but probably I will get acquainted with epidemiology in my microbiology class. I did my bachelor's degree I have my bachelor's degree in biochemistry, so I was pretty interested to learn more about epidemiology because I've been on the side of the research. I've done the research part, so I wanted to see also the side of epidemiology, how you can know the cause of a disease, but most importantly, I'm so interested in infectious diseases, and I hope to go to medical school in the future, so it's like it's a good part.
Hi everyone, my name is Simone Capsule. I did my bachelor's in public health. My concentration was healthcare administration. When I did my internship, however, I was more interested in community health, and so I actually I was not a lot, just from my internship, a little bit of experience with epidemiology there. I had worked with United South and Eastern Tribes, and it's an organization that works with 26 different Native American tribes spread across the country from like Maine to Florida, part of Tennessee and whatnot.
And I got to work with their biostatistician and their senior epidemiologist, and got to use EpiInfo a little bit during then. So that's some experience I have with epidemiology, and through that experience, I discovered my passion for community health and being a health educator, not so much on the academic level, but more of the public and reaching out to the communities. So that's why I'm here in the master's program, and my concentration is on community health.
Hi everyone, I'm Anthony Peluso. I got my bachelor's in biology and sociology from the University of Pittsburgh in April. But then I just moved here a couple weeks ago. My concentration is community health, but I've definitely had some experience with epi in my biology classes, especially micro, which I just took my senior year. So I have some experience, but my main interests are health disparities and social epidemiology. So that's kind of my social, I kind of chose the social science route, but I'm excited to be here.
I'm Lynn Zhao. I graduated with a bachelor's in biology from Furman University in Greenville, South Carolina. I don't have any really direct experiences with epidemiology, but I will say that I took a class in medical sociology and philosophy, in relation, like ethics in relation to medicine, and that really opened my eyes to kind of how health issues affect social, just impacts the social structure of the community and just the social issues that brings up, and also the importance of policy making and how that affects the community. My concentration is in health services administration. I've always been interested in healthcare for as long as I can remember, and so I'm pretty excited to learn more about epidemiology and how that ties to all my other interests.
My name is Cindy Barrett. I got my bachelor's in biology, and now I'm in the master's of biology program here at ETSU. I've had some experience with epidemiology through micro and whatnot, but now my research focuses on a fungal pathogen affecting a rare village, and it's spread through this region. So I was kind of excited to find this program, even though it's out of our little brains. But I just hope this class will help me better understand maybe how it spreads, where it spreads, and how to control it.
Okay. Hi everybody, my name is Amin. I get my medical degree from University of Stockholm. Actually, I've always wanted to be a surgeon, but in my 5th year, we went to a rural residency. That's in the east of Sudan. Then the department made us do a research about few stuff, so I couldn't start anyway. So after that, I realized that, well, actually, to be a surgeon or to be a doctor, that's like working at the top of the health system. What we actually need is the whole health system is kind of corrupted, So that's why I needed to, study epidemiology, help me with researches and stuff. That's basically why I'm here.
Hi, my name is Ashley Dowrick. I graduated with my bachelor's in exercise science from Kathleen University. I have no experience in epidemiology. Basically, all my background is in the physical aspect of health, and I just want to broaden my horizons, and I'm very interested in the politic aspect of public health.
My name is Joanna Harden, and I got my bachelor's degree in environmental science. My experience with epidemiology is pretty slim. I've done a lot of work as a field biologist studying plague and prairie dog populations, but not with human health. So this is brand new to me. I'm looking forward to learning something new. I am aiming for an MSCH degree, so I just want to see how this can be applicable to what I might do in the future.
I'm Angie Hegeman. Let's see, I was a first-generation college student back in the early 90s. So my bachelor's degree is in English education. I was a high school English teacher for a little while. Found myself drawn to sort of the high-risk youth who were in the classroom and didn't want to do public education. So then I began working in the nonprofit sector with high-risk youth. Simultaneously, I achieved a master's in counseling, going part-time for lots of years, and starting to then realize that the high-risk youth that I was working with, when they went back into the community, every year what was happening was with the youth, their faces and names were different, but their situations were the same. And so I heard about this thing called public health. It could change communities, and I just sort of fell in love and started working in that field as a coalition leader and a director of substance abuse prevention services in Northwest North Carolina. And so I believe that I probably had a good bit of experience with epidemiology, but not in a formal way. We were always looking for the root causes and what was happening in each community and what their local conditions were. So I'm really excited to learn the science behind what I spent 7 years doing. I'm now employed full-time here with the ETSU College of Public Health. I'm the program director for a funded research study on prescription drug abuse. So I think what I learned in this class will very much inform what I'm doing in my current work, and I'm also enrolled as a doctoral student in the DRPH, the Doctor of Public Health program with a concentration in community and behavioral health, but I don't have an MPH, so I need to get those core courses. So happy to be here.
Hi, I'm Gabriella Caldera. I'm a lot like you, Andy. I have a bachelor's in cellular biology from 21 years ago, so this is really new for me. I'm probably the short bus rider. I have a master's from 15 years ago in sociology. I have limited knowledge in epidemiology. I work for the government, so I'm hoping to use a lot of the knowledge that I learned here to apply to investigating and discovering some of our problems that we face with some of our situations that our guys go into. And yeah, it's a pleasure to meet you all. Don't have any technological questions.
Hello, I'm Olivia Musi. I just completed my bachelor's degree in English from Penn State, and I don't really have any background in epidemiology, but I've worked in law, like immigration law, and I've also worked in a couple of healthcare facilities, so I figured that public health administration and policy would probably be the best way to kind of put together two of my passions, so I'm here.
I'm Carolyn Stanton, and I just graduated from ETSU with a bachelor's in chemistry. I was pre-med until I did some medical mission work in Uganda. I've been there 5 times. And while I was doing those trips, I got to be in charge of an eyeglasses project. And through that experience, I learned that I really didn't want to be a doctor. And public health is actually what I have skills for. So I don't have a lot of, well, actually hardly anything in epidemiology. But when I was in Uganda, like each different area we did clinics, there were like different diseases that were primarily in those areas. And I was kind of curious, like I think maybe what I learned from this course might help me to understand what might be done about a situation like that. Because like in certain places we would have brucellosis in this area, and 2 hours away there would be TB. And it was just like everybody would have this, everybody would have that here. Anyway, so I'm really interested in learning more in this course and potentially thinking about my experience in Uganda with it.
I'm Sherry Blankenbeckler. I too just received my bachelor's degree August 14th, as a matter of fact, in human services with a minor in public health with an emphasis in healthcare administration, and I fell in love with administration work. That's what I want to do. I have no experience whatsoever with epidemiology, and I'm looking forward to learning from it.
All right, hello, my name is Randall Crutcher. My undergraduate degree is in microbiology and biochemistry, and I just kind of chose that path, not because I knew where I was going, that's just what I loved. And that's also where I discovered epidemiology as an elective, and to me it made sense that I would be able to apply the knowledge that I gained through those classes to the public. I'm specifically interested in like socioeconomic and cultural causes of infectious and chronic disease. So that's why I'm here with you guys, and I'm excited to learn from y'all and you.
I'm Yemi Adeniran. I'm from Nigeria. I had my medical degree in Ukraine 3 years back. So I go back to Nigeria and practicing the same. And yeah, I had lots of experience with epidemiology through my med school, and also I was involved in the research of endocrinological diseases in a particular area in Ukraine. So I was exposed. Then when I go back to Nigeria with, peculiarities of some diseases to some parts of the country, so I was involved in a little bit of research in our work practice. And my expectation is just to learn, a lot of things that will, especially in policy making, that will, influence the decisions that we make concerning our health system, and also infectious disease.
My name is Gabrielle. I got my bachelor's with a double major, exercise science and general science with a pre-med in physics.
First and last name.
Gabrielle Gaffray.
Thank you.
And I had a pre-med in physics, exercise science, general science. I am getting my MPH concentration in epidemiology. I was a peer health educator for all 5 years of undergrad, and so I guess my experience is kind of looking at the college population and the things that influence students as they're going to school. And also my mom suffers from heart disease, so I have a pretty huge interest in chronic diseases and how socioeconomic status and all of that impacts how that happens.
Hello, my name is Randall Simpson, and shout out to all my English degree havers. I got my bachelor's in English and political science. I have absolutely positively no experience in epidemiology, so also shout out to everyone else who's like, yeah, neither. I worked for about 4 or 5 years as a case advocate for Catholic Charities of East Tennessee, Catholic Charities in Chicago, and a nonprofit called the Safe Haven in Chicago. And I worked with a lot of youth who, they were about 10 years younger than me. They were pre-teenage years and had been addicted to drugs for many years. And I was like, well, what happened to the DARE program? I thought that would work out, but it did not. So I'm really interested in the socio-economic and the cultural implications of public health. I think just reaching out to communities that, have been ignored, especially in rural areas or deep urban areas, that's what I'm interested in. And epidemiology actually will teach me how to do the research to do what, when, where, why. So I'm excited.
I'm Sarah Howard. I got my bachelor's in biology with a chemistry minor in 2014 from Tusculum College. I have a roundabout experience with epidemiology. I did undergraduate research in organic chemistry, creating drugs that are more cost effective for the third world. And so you'd look at something and be like, we don't have this in the United States. Why don't we have this in the United States as far as diseases? So I'm kind of looking forward to working with people and not staring at like TLC plates and trying something more. So.
All right. My name is Kathleen Collins. I got my associate's degree in radiography, and then through ETSU, I did their bachelor's completion program online and got my BS in allied health with a concentration in radiography. So I'm very familiar with D2L, but I'm really excited to be on campus now. Let's see. I worked for several years as a radiographer at East Tennessee Children's Hospital in Knoxville. And I want to do graduate school just to continue my education, and public health just has so much to offer and so many opportunities. And specifically within epidemiology, I'm interested in environmental and social epidemiology.
My name is Obu Emmanuel Chukwemeka. I got my bachelor's degree in medicine and surgery from Nigeria. And I've been in clinical practice. I was in clinical practice rather for 3 years. After which I worked with the Federal Ministry of Health in the Ebola virus disease surveillance team. You must have heard about how Ebola is affected the West African countries. So my country, through the efforts of the surveillance team, were able to kick Ebola out. And basically, I'm interested in epidemiology with a research interest in infectious disease epidemiology, because I really want to look at the modeling of infectious diseases, the distribution,
things that actually determine infectious disease in third world countries like mine. So I believe that the epidemiology lectures will go a long way to enable me to achieve that.
Yeah, my name is Muyiwa Atebule, but I like to go by Philly because it's easier for everyone.
Thank you.
I'm a medical graduate from Russia. I'm from Nigeria. I worked in Nigeria for a while in both clinical practice and on field with several NGOs, including WHO and USAID. I was involved in several outreaches, HIV outreaches and meningitis outreaches. And then I was also involved in research, meningitis research and HIV research. My desire for MPH came from those researches and the outreaches I participated in. I realized that preventing the disease is far better than curing it. Doctors are trained to cure the disease, but public health helps you to prevent the disease, and which is far better than medicine. Yeah, that was why I applied and pursued a career in public health. Thank you.
My name is Reem Tariq, originally from Kuwait. Parents are from India. And I got my bachelor's in genetics and cell biology from Washington State University. Then I took 4 years off, and then did some work in Houston, moved to Tennessee, doing my master's in environmental health. So I do have some experience with epidemiology because I studied genetics and cell biology, so some of the classes that I took did touch on that. And my research experience was mostly focused on things like neuropharmacology. I did some work with plant pathology and some cancer research. So the reason why I'm really excited about this class is because it has broad applications. Epidemiology could basically apply to all of those things that I did research on, which is why I'm really excited to be here.
Hi, my name is Emma Chandozi. I'm originally from Nigeria, but I don't have an accent, sorry. I am currently in the MD and PH program. I just finished my 3rd year of medical school over at Quillen, and I always knew I wanted to do public health. My concentration is in health services, administration, and policy. I hope to one day go back to my home country and help establish clinics also in other developing countries around the world. That's really my passion. I guess my only public health epidemiology experience is, like, I think throughout my whole 3rd year of medical school, where being grilled in on evidence-based practice, and learning like different charts and different algorithms of different things, and it's all based on epidemiology. So it's really exciting to learn the basis of it. See my expectations. I'm just excited to absorb as much as I possibly can, and I'm having this break from medical school. I hope to really contribute also to the college public health.
Hi everyone, my name is Naveen Jonathan, and I just finished my bachelor's in public health from ETSU, and I just actually finished it in last summer, so last summer was my last class. When I was taking my courses in public health, Mr. McKamey was our instructor for epidemiology and biostatistics, so he came to me first day and during that time, and he said, you are really good in this, and you should do your MPH in this, and that's why I'm here.
Very good. That's a start for Mike. Go, Mike.
And then I have Dr. Megan Quinn. She's a very good friend. We do Zumba together in Wellness Center. So I talked to her, and she said, yeah, you should do this, and so that's why I'm here.
So see that teamwork.
Right. The other thing is that I'm from Pakistan, so all of the early education was there. I came to United States back in '96. I do have a first-line experience with the prevalence of the disease in the third world countries. At some point in the life, I do want to work with WHO or with CDC overseas in a third world country, and I found epidemiology is the best way to prevent the disease, to find the cause of the disease and, break it at that point. So that's why I chose to be here.
Mm-hmm.
And last one. My name is Melissa Breck, and I'm doing my concentration in community health. I actually live in Asheville, but I'm commuting here because I'm working with Dr. Brooks across the way on a project because there are two huge hospitals merging here in East Tennessee, Mountain State, and Wilmot. So we're doing research to see what the community's expectations are as far as what healthcare will look like here over the next 10 plus years. I'll be commuting. But let's see, my background, I'm actually a public school teacher by training. I got my master's in teaching from Chapel Hill about 5 years ago. I've been teaching middle school in Asheville for the past 4 years. Glad to be a student again. And before that, I actually worked in nonprofit and taught HIV prevention education to high-risk populations in Cincinnati for a few years. So my background, my only real experience with epidemiology is with HIV that I'm excited to learn.
Okay. We are going to continue and see if our synchronous participants can contribute to this learning session. Shannon Tipton, can you hear me? And introduce yourself. I don't think we can hear you. Shannon, can you turn up your mic? Thank you for joining. How about Joy? Joy Ramsey?
Hi, everyone. Can you hear me?
Yeah, we can hear you.
I'm actually retired Navy. I did preventive medicine in the Navy, so that's where I got my first experience with epidemiology. When I retired from the Navy, I got out and went and got my undergraduate in environmental health science. I've spent the majority of my work experience doing food safety, and I'm now actually in Baghdad, Iraq, working at the embassy doing public health here for Department of State and contract workers on the complex.
Hey, thank you for joining us. And how about Fred Downs?
Yes, can you hear me?
Yes, perfect.
My name is Fred Downs. I live in Gastonia, North Carolina. I'm an ER nurse right now. That's full-time. My bachelor's degree is in nursing. I was the research chair of the hospital research council, which is kind of how I became interested in epidemiology. Did a lot of elbow rubbing, I guess, with research reports and epidemiologists and epidemiology. So that kind of piqued my interest and why I wanted to investigate epidemiology. And so far, I mean, it's kind of interesting, and I'm really looking forward to it.
Great. Thank you, Fred. And let's turn you off. Okay, Aisha. Hello, Aisha. I'm not sure. You're on the phone. Not sure if you will be. Let's go up to Alexis.
You just muted her.
Oh, I did. I did. Alexis.
Hi.
Sorry.
I'm from Bethlehem, Pennsylvania, and I'm pursuing my MPH in public health with a concentration in epidemiology, and I guess my main interest in epidemiology was sparked from when I took my Intro to Community Health Education course, and one of the course topic was trying to figure out how did a group of people from a picnic get sick, and just trying to see who ate what, at what time did they eat something, and just all that problem solving that I like to do, and just combining it with health. So I was working as a research coordinator, and now I just want to focus full-time on my master's program and just see where I can go from there. Ultimately, I'd love to work at a public health department or a community health department, understanding underserved population and what could be done to help provide better resources.
Okay, that's it. That's great. All right, let's see. Let me go back here. Just in terms of continuing along with my introduction, Pittsburgh, then I received my PhD in epidemiology at University of Texas School of Public Health in Houston, Texas, and stayed in Texas then what I thought was almost forever. I worked in the medical center at Baylor College of Medicine in the Department of Pediatrics, and I was directed epidemiology for that department and helped work with faculty in terms of primarily developing research programs and having an office that was a resource for their study design and data analysis. The most recent project that I directed was the National Children's Study. All my research has been in childhood health. National Children's Study was looking at the effect of the environment, genetics, and the interaction of environment and genetics on child growth, health, and development. And environment was defined very broadly, anything from chemical exposure to their social milieu. And we were recruiting pregnant women at prenatal care facilities and at birth and at delivery hospitals with the plan of following these children for 21 years. It was going to be the first cohort study of child health in the United States ever done. Epidemiologists are all very jealous of our colleagues in Europe that have these wonderful cohort studies because of the way that medical and health records are linked and can so easily follow population health from birth through death. Unfortunately, the project was shut down by the federal government, and hopefully will be redeveloped and repackaged so that we can eventually get a child health cohort study in the United States. But the study itself came from the Child Health Act of 2000, and it was a really grassroots effort of constituents of our members of Congress, parents and teachers and health professionals going to Congress saying, what's happening? We are seeing an increase in asthma and autism and diabetes during childhood. What's going on? Is it the environment? And so that was the reason for Congress to then mandate the National Children's Study. It became a line item in the president's budget. We were able to do some interesting formative research, but our participants were not followed for 21 years. So we started, you all came so early, it's time for a break, okay? So let's take a 5-minute break and resume.
I could be wrong. Maybe you should re-listen. Well, maybe we're next week. That'll work out. There you go.
I mean, they all have operating where he checks out.
I do, yeah. He was a co-teacher. Yeah, he's. Yeah, I really like that. Yeah. Have you finished the CSC? That's it? That's finished, I think, last month. Oh, okay. Yeah, so it's exciting. I met him through, I know someone who's a second year student, and she also lives in Nashville. Okay. So he was looking for, he lives in Nashville. He does. He was looking for someone from community health to help out on the project to epidemiology people already. So he wanted to come to community health, so I met him. So that's how it happened. But yeah, he's great. He's a good kid. He's really very laid back. He is. Yeah. So yeah, so I started there last week. He wasn't like he fighted with him once in time, but to get him in he was more like a friend. Yeah. I know. I keep calling him my boss. Have you met I'll probably, I have the community health class in that's cute. Are you community health? We met in the orientation. I wasn't sure. Okay, so I was late. Okay, great. Yeah. Oh, I was completely different. I mean, you never shot that much. No, I love teaching. I did not do stuff in the classroom. I miss it's never got easier. I was just years and it felt like it's not really hard the whole time. But I think for public school teachers, like all my friends are public school teachers. I have a lot of friends. I've been having it on. It's a challenge. And there were parts that I really loved and I missed it, but there are parts of it where I'm like actively happy. I started with crab, like how hard. I would not. Especially, I don't know much about those kind of public schools, but that's not public schools. They just keep adding more stuff onto it. We haven't got copies of it's all over there.
Work on it right now. Everything, getting to everyone. You're kind of like figuring out what you want to do.
My mom gets to finish longer on she gets up earlier, but she looks great on first night. Like my new the next day. I was on crazy school too.
Yeah. And then well, I've done it.
The first chapter was
I got into my
I certainly learned a lot through the introduction, and I heard, All right, where are we going? Settle down. As I was saying, I certainly learned a lot from those introductions, and I also heard a lot of similar themes and topics going through. Microbiology, I think, was a heavy hitter in terms of experience in this room. Human health populations, the distinction between medicine or clinical medicine and public health, the fact that we are interested in population health versus an individual's health, but epidemiology can certainly inform medicine, and I think I heard that from the description from Emma, the description of evidence-based medicine, and really the gathering of epidemiologic data which drive some of those evidence-based decisions and programs. Policy, several individuals interested in policy, and that's another very exciting key thing that epidemiologists contribute to. It is epidemiologic studies and data that can help to drive policy. I particularly think that policy is just key to the population's health. It's so hard to change behavior, and we in public health keep trying to change behavior, and gosh, if we were able to change behavior effectively, we would all be perfect, and we know that we're not. But, hey, put up a stop sign. Seems to work that policies such as that reduce the risk of accidents. And then patterns of disease. Many of you have had some amazing experience in this country, other countries. I like the description of, oh, gee, we had a pocket of TB over here, and then we had a pocket of some other disease here and here. And, yeah, that's epidemiology, and those are great experiences that you have had. I'm glad you're still thinking about them and thinking about how your new acquired knowledge can help you to expand the stories that you tell about your experiences. So back to what is epidemiology, and I do not mind during class time if you are using anything to access the web. That is so much of our daily lives of constantly trying to look things up, acquiring new knowledge, and as long as what you're doing is at least somewhat related to our activities in classroom, please go forward. Any favorite definitions, because there are different definitions of epidemiology. If the last time I was looking, there was an article in one of the epidemiology journals, and it listed the definitions of epidemiology and how it has changed over time with the growth and changing issues in public health across time. And so let me have a volunteer. What is epidemiology? Go ahead.
Epidemiology is the study of disease distribution within the population and also the factors that determine the distribution of that disease.
Okay, I saw another hand over here. If it's the same thing, that's fine.
I can repeat that.
Please do. We want to make sure that we all have a concept of epidemiology.
The study of the distribution and determinants of health-related states or events in specified populations and the application of the study to control health problems.
Mm-hmm. Okay, so you did add to that definition. Any other additions? Yes.
The study of diseases, their determinants, their deterrents, and their distribution in the population.
How many? Did you have 4 Ds in there? There you go. Yeah. That's a good way to remember things. Yeah. Have anything else in the back of the room? Yes. Go ahead.
I just always look at it like you're studying disease patterns, like looking for trends within populations. Like that's my favorite way to look at it, like kind of being like a CSI investigator for disease patterns. That's what I think, and why it affects some people and doesn't other. Like part of the reason we struggled with Ebola for so long is because as soon as we got there to study it, it was gone. It's like it'd be there for a week or two and then it would disappear. So that was like what I found interesting is like epidemiology of certain diseases. It's hard to find sometimes.
One of the classic descriptions of a epidemiologist is a disease investigator. Shoe leather epidemiology, where we got out on the streets and observed patterns and tried to figure out why disease was occurring in the population. My favorite definition right now is the science of understanding the distribution and determinants of population health so that we may intervene to prevent disease and promote health. I like this definition because science is involved in the definition. We are a science. Epidemiology is the science of public health. It is the pillar of public health. It also includes population health, where it's beginning to really become a throwdown term, population health. Everyone is talking about population health. Okay, so let's keep up with the times. And we want to intervene to prevent disease and promote health. And so as epidemiologists, we should be finding the answers that lead to conditions that shape healthy populations. We should be interested in an epidemiology of consequence. We learn an awful lot. We collect data. We write reports. We write journal articles. But what's the consequence of this work that we do? We need to get out there and apply epidemiology. And that's one of the reasons why I chose to come to the College of Public Health at ETSU. When I came here for some visits and I spoke with the dean and the faculty and the staff, there was an emphasis on applied work. And that I was to the stage where I realized, that's the important thing. I can write a lot of manuscripts. I can continue to analyze data, but I need to use my knowledge and put it forward. Apply epidemiology so that we can continue to have good population health. Now, epidemiology of consequence is a phrase coined by Sandro Galea. He's an epidemiologist and currently dean of Boston University School of Public Health. And if you read the epidemiologic literature, you will see his name. Is disease random? Why do you say no?
Because some subgroups within the population might be predisposed to the disease, right? It could be some kind of exposure to something that's detrimental, or it could be genetic predisposition. So,
okay, any other thoughts?
Because the people who develop the disease may have basically the same characteristics that lead to the development of the disease, but it's not random.
If disease were random, epidemiologists would be out of a job. Remember, we're looking for patterns, okay? Random would just mean, oh, okay, disease here, for no reason whatsoever. But when we start our investigation of health or disease outbreaks, we are looking for something that relates the cases to each other. It could be because they have all been exposed to the potato salad at the church picnic, okay? Or they could be exposed to high levels of ozone on hot days they live next to a highway, a very busy highway. Or they could be of a similar birth cohort. It's characteristics that we as epidemiologists are looking for that make someone at higher risk than someone else for the consequence. Whether it could be a good consequence, it could be a bad consequence. So once again, I'm always going to redirect you back to sort of the nitty-gritty of the courses that we teach, our core competencies in our learning objectives. MPH core competencies are important because of the MPH comp that many of you are going to be taking in a year or so. And also, if you are interested in taking the exam that will certify you as a public health specialist or as an epidemiologist, and that is something that you pay for and you come out certified, but that is also based on core competencies. And so for this week, we're going to be applying epidemiologic principles. We've begun to throw out some of the terminology or the jargon that we use as epidemiologists. For several of you in the course, this is a review for you. I understand you've had epidemiology before, and that's okay. This is a review. But reinforcement is important. For some of you, you're learning a new language. The discipline of epidemiology has certain terms that we use that other disciplines either don't use or they have a different term for it. So that's why sometimes it's difficult for individuals of different disciplines to come together and study a similar issue. It takes a while to become comfortable and with the terminology being thrown around the table and to finally get to the point where you say, oh, now I understand. We agree. But that's your approach. This is my approach. And boy, if we put it together, wouldn't we be stronger approach? So each week, You'll be introduced to new terms and concepts and principles. And also for sort of chapter 1, demonstrating ethical choices, values, and professional practices implicit in public health decisions. Fascinating timeline of epidemiologic history that's presented in the lecture slides, much more information than was presented in chapter 1, but I hope you'll take a look at those lecture slides and learn a little bit more about the history and fill in things. So we've got 5 objectives of epidemiology that were presented to you in chapter 1 of Gordis. And we've learned that epidemiology is focused around etiology or cause of a condition, a disease, an outcome. Those are terms that can be used interchangeably. A statistician may call it a dependent variable, and the cause would be the independent variable. And so you've got your statistical model with your independent variables on one side of the equation with your dependent variable on the other side of the equation. And as epidemiologists, we strive to find the cause of disease. And there is a continuing significant debate among scientists, that epidemiology can never demonstrate the cause of a disease. Okay? And that type of discussion bubbles up from, okay, in very specific deterministic terms, one can say smoking does not cause disease. It's the smoking at the cellular level that we don't know potentially the exact mechanism. The epidemiologist is not drilling down to the mechanism. But we do know at the population level, if we reduce cigarette smoking, we can have a significant public health effect on cancer, lung cancer. We as epidemiologists say it was an epidemiologist that determined the cause that smoking potentially increases someone's risk of lung cancer. Now, does everyone that smokes get lung cancer? Why is that?
There are other factors that lead to lung cancer.
That's right. That's right. That's right. But it potentially increases someone's risk for that outcome. And so, just as a warning, if you have a conversation this weekend with friends, and you're saying, "Oh, I'm really excited. I'm taking epidemiology because epidemiologists determine causes of disease," you may start a friendly discussion argument with your colleagues who think differently and say, "Well, we don't really get to the bottom of things, but hey, at the population level, we do a great job." Now, burden of disease is also very fascinating. We had some introduction to that by descriptions of some of your experience. Different populations have different burdens of disease. If you are in New York City, the diseases that we list, the top diseases that are affecting the population of New York City residents are potentially going to be very different from the diseases that are listed in Northeast Tennessee. Okay. And bringing back into the importance of watching patterns, watching things change over time so that we can always shift gears and focus on those diseases that are causing burden. Back in the 1980s in California, there began to be case reports to the Centers for Disease Control by physicians who began treating some young men with a very strange immunodeficiency, a disease. The physicians had never seen it before. They weren't sure what it was. They didn't know what caused it. But as these reports began to come in, we saw that the burden of disease in that area of the country was changing, and it began to spread. Over time, the epidemic of HIV/AIDS continues to change in terms of the populations that it affects the most. Started in with most focus on white males. As it moved across the country, in the South, we began to see young Black males with higher prevalence and incidence of AIDS, HIV. So patterns are important. Watching the burden of disease as it changes over time, over geographic area, person, place, and time. Person, place, and time. Just keep repeating that to yourself. So those are, that's how we, as epidemiologists, try to organize the context of disease, the variables associated with disease and health. What are the characteristics of the person? What's the characteristic of the time? Is it changing across time? Place, where am I? Natural history of disease is very important for epidemiology because disease changes over time in terms of, as it may, someone is infected and they show no clinical signs or symptoms. There's an incubation period. How long is that incubation period? For how long can that individual infect others? And so knowing the characteristics or the natural history of disease allows us to put in place intervention and prevention programs at the appropriate time so that we can stop it from going any further. That's what we're trying to do. We're trying to stop or delay natural history of disease. Epidemiologists are evaluators. When we suggest that a certain program should be put into place, we work with the program initiators hand in hand so that we can monitor the data and determine whether or not that intervention is a go or a no-go. Not all interventions work, and some are not appropriate for the person, the place, or the time, and may need to tweak a few things. And then, as I mentioned previously, epidemiologic data, epidemiologic evidence, epidemiologic studies are the foundation of public health policy. We have our colleagues in government, they call upon us as scientists, as epidemiologists, and say, okay, hey, this bill just came through. Is the evidence there? Should I be supporting this bill? Provide me the data. I will only support the bill if I know that the data are there, that I can stand up and say, and point to the data, show my graph or whatever. So, exciting. Okay, now let's see, how do we can we get this out of the way? Because you can't see. There it goes. Actually, I'm going to put Alexis all the way down here. Sorry, Alexis, you're now at the bottom of the screen. Okay. Epidemiology is a study of how disease is distributed in human populations and the factors that determine this distribution. Why do some people develop a disease, why others who seem to be exposed in the same manner do not? Epidemiology is based on the belief that there is a reason disease develops as it does, and disease occurrence is not random, and it does not occur by chance. And because of that, we have a science. Historically, epidemiology began studying infectious diseases. And that was just because that's what the landscape was at that time. In the 1800s, early 1900s, infectious diseases were the primary contributors to death, causes of death in U.S. populations, most populations. And so epidemiologic programs began with procedures and methods to study infectious diseases. The Epidemiologic Intelligence Service, EIS program, started as a program for infectious diseases. Most departments of epidemiology, when they first started, they focused on infectious diseases. And now we coined the phrase modern epidemiology. Our textbooks, if you go into an epidemiologist's office and you see their textbooks, for those of us that still covet textbooks, you'll see all of our introductory texts are focused on infectious diseases. And then there's this larger book, usually by Rothman, Modern Epidemiology, where we begin to build our science so that we could now incorporate chronic diseases, disabilities, health outcomes. And so we now have the ability to cover a wider spectrum of disease, but it's actually, it's what's happening in the population that's driving us in that direction. Let's see, let me get to. For example, here we have the top 10 causes of death in U.S. In the 1900s. And infectious diseases, okay? That's where we started with cancer and accidents, the bottom of the list. And now when you look at 2009, the pattern has changed. You've got heart disease floating to the top, followed by cancer, lung diseases, strokes, accidents. I was looking at similar data for 2012, 2013, our most recent data. Heart disease still at the top with cancer, chronic lower respiratory diseases. The only thing that's changing just a little bit, but it's certainly not significant, is accidents. Going above, flipping with stroke or cerebrovascular disease. You know, why is it? Is it something that's changing in the medical field? Is our environment changing? Are we living in environments that place us at higher risk for accidents? I don't know, but all good questions. Our department is the Department of Biostatistics and Epidemiology, and we all get along because biostatistics and epidemiology goes hand in hand. You can't have epidemiology without statistics. You can have statistics without epidemiology, but then they wouldn't have any fun, and so they'd be, you know, trying to get us into their department anyway. You will see as you go through many of the exercises, the activities during this course, that math is involved. Please do not be intimidated. Do not be intimidated in Biostatistics 1 either. It's something that you can accomplish, and we will not throw formulas at you that will not be described to you. In terms of biostatistics for Epidemiology 1, the concept that you should really become comfortable with is what goes in the numerator and what goes in the denominator. Okay, because we're dealing a lot with proportions, rates, ratios, and to get all of those, you need to know what goes in the numerator and what goes in the denominator. Talked about person, place, time, demographics. Demographic characteristics. What are demographic characteristics? Or an example of a, go ahead. I'm sorry?
The age of the population.
What else?
Ethnicity.
Yes. Characteristics that describe your population. We've heard several. Could be ethnicity, race, age, socioeconomic status, economic status. Environment. Epidemiologists, we span the spectrum of the environment. We have environmental epidemiologists that are the classic environmental epidemiologists that are work with the built environment or the chemical environment, those classic exposures. We have other environmental epidemiologists that are interested in social conditions, the social epidemiologists. And then we've discussed our major causes of disease. An important role of epidemiology is to monitor morbidity and mortality. Some more terms. What's morbidity? Disease. What's mortality? Death. a lot of jokes about epidemiologists that all we're concerned about are dying people, okay? We've all heard that joke, no more. Okay, morbidity and mortality of different diseases and how they may change over time. And we showed you the example of the change between 1900 to 2009 to 2012. Recently we're not seeing big changes in those patterns of the top conditions that take up the percent of total deaths in the U.S. We speak a lot about prevention, and we've learned that there are different types of prevention. Prevention can also be thought of as on a spectrum, going from primary prevention to secondary prevention to tertiary prevention. Has anybody involved in a primary prevention program? And if so, an example.
I'm involved in celebration of World Diabetes Day, and we were about how to prevent diabetes.
Okay. There's somewhere that
the top was on.
Community. I'm sorry. Okay. User number 2. Yeah. Thank you. All right. Okay. I'm sorry. You had an example.
Oh, same idea. Teaching HIV prevention to students before they're actually exposed to any risk factors.
That's right. That's right. And so you're trying to prevent the initial development of whatever you may be concerned with, and you know, if we can do that, that's where we want to be. We want to be at primary prevention, but that's not always possible. And examples of secondary prevention. Yes.
Like screenings, like a PSA screening for prostate cancer, or like a mammogram type deal.
Screening. Yes, screening for cancer. Why do we want to screen?
Early detection.
Early detection, right. And we do it because there's something we can do, okay? Every screening program, don't screen for something that you don't have a fallback for. And then tertiary prevention. Yes?
Can exercise be reducing, like, rehabilitation?
Oh, okay, sure. Someone that goes into physical therapy and is prescribed some type of an exercise program because they have some disease, or trying to reduce the impact of that disease so that the individual has a better...
Would that be under primary? No?
You know, it just depends at what point you actually have interaction with the population or with the person. If they already have the disease, it would not be primary. Primary is no disease. Okay. And then secondary and tertiary.
I have a question.
Yes.
So, like, screening for genetic predisposition for cancers, would that be primary? That would be, right? Because the cancer.
It would be secondary.
Should it be secondary?
Mm-hmm.
Because there is no existing condition at that point. Yeah. Right?
Could be. It could be. I can see what you're saying in terms of if the condition is not there yet, but you are screening for a risk factor.
Right.
Yeah. Yeah. So that's a very good example, and that complicates things. And I would put that in potentially in two different categories, and could potentially justify my reasons for doing that. But that's a great example. Any other questions that will help us think about this?
Is chemo tertiary prevention? If you have cancer, is chemo kind of the way of chemotherapy is tertiary or not? Okay.
And so who would like to answer that question? And is that what your question was? Is it tertiary?
Yeah, I just wanted to
yeah. You wanted to confirm what you thought. It's been confirmed by your colleague. Mm-hmm. Yeah. Yeah. Okay. Any other questions? Great questions, because you're making us all think. Sometimes things seem like, oh my goodness, that should be obvious, but it's really not.
Well, in that same vein, would that mean that a lot of treatments for diseases are just tertiary prevention?
Even if it's just impacting that one individual? Because something like cancer, you know, okay.
Mm-hmm. No, go ahead.
My question was, you know, we're thinking about the big population here. So if you're treating one person for chemo, mm-hmm. their recovery from that cancer doesn't necessarily impact cancer spreading from that person.
That's
you
right.
know,
That's
so
right. That's right.
Is treatment still thought of as tertiary, even if it's just for one?
Mm-hmm.
Okay.
Mm-hmm. Mm-hmm. Yeah. What else? Okay. Food for thought. Sometimes things aren't as straightforward as possible. An example for secondary prevention: screening for high blood pressure or high blood glucose. Early detection and intervention can help prevent severe later complications, such as stroke or heart disease. And then tertiary prevention: treating someone with severe rheumatoid arthritis with medications and exercise so that the person remains functional and further disability is minimized or prevented. Okay, during Chapter 1, you also learned that there are two broad approaches to prevention. Yes, go ahead.
Let's take you back. No, yes, you mentioned that examples of secondary is screening of blood glucose. Mm-hmm. For example, we have a patient, you know, it can be in two ways. You have someone that is diabetic. Mm-hmm. Definitely, you have to be checking the glucose, you know, mm-hmm. if the drug is really working. Also, how do you know if someone is diabetic? They come to the hospital, you check their sugar. Okay, madam, you're fine. Apart from the lifestyle, you know, modification that you explained to them, so it can either be primary or secondary.
Mm-hmm. Mm-hmm. Right. It depends whether or not the person already has the disease or does not have the disease. That is correct. Or is that how you were thinking it?
Yeah.
Yeah, right. Once again, if they have the disease, they don't have the disease. If they don't have the disease, you know, you're still primary prevention, trying to do things so that they don't fall into the numerator. Mm-hmm. That's what happens. Once, if you're looking at disease or death, that's what's happening to your rates, your risks, your ratios. You're coming out of the denominator and going into the numerator. Okay, population-based approach. You're doing something for an entire population, a community, a school. Your population can be defined by any terms. It can be a small population. It can be a large population. Or high-risk approach. If you already know the risk factors for your outcome, then you can target your intervention to a high-risk group. So in terms of the epidemiologic approach, we start with data, and it's usually descriptive data. Descriptive data that provides us information that allows us to begin to formulate a research question or a hypothesis. As we look at our descriptive data and we make our observations, we begin to formulate potential patterns that allow us to begin with very simple questions. Is this subpopulation at risk for this outcome? We always want to make sure that our research questions and our hypotheses are based on data. We are trying to find the truth. We're testing whether or not what we're seeing is by chance occurrence. We want to continually test our data, ask questions about data. Were the methods used to collect the data valid and reliable? Do the data represent reliably a population? Do they represent the target population that we're interested in? Because remember, person, place, time, if you are studying group A and all your data came from group B, you may intervene with a program that is useless for your group B population because they have different characteristics. They are at a different stage in their life. They may be a different birth cohort that was exposed to different things during their lifetime. Another relatively new concept that is creeping into public health is the life course approach. From the time that someone is born till they are an elderly individual, what are they being exposed to over time? And as they are being exposed to this very broadly defined environment, at what stage of life are they when they are having this exposure? If you have a chemical exposure is going to have a very different effect on a 2-year-old versus a 50-year-old. And so it's that whole concept of thinking about the entire life and what happened to that person over time. Descriptive epidemiology, person, place, time. Once again, what it is in its name. It's describing something. Descriptive epidemiology does not attempt to determine the cause of disease, but it is information that can be used to get to the next step of epidemiology, which is analytic epidemiology, where you can begin to test hypotheses, test whether or not there is a cause-effect association or a correlation. We categorized epidemiology into these two categories. Are you doing a descriptive study? Are you doing an analytic study? You'll find later on that epidemiologic study designs are placed into these categories. There are some epidemiologic study designs that are completely descriptive, and there are other epidemiologic study designs that are analytic. You've had the opportunity to read a little bit of epidemiologic history, a little bit about childbed fever, smallpox, and cholera, all fascinating stories, just because these individuals were able to make such amazing observations with so little technology. Think of what is available for all of us now. And, you know, John Snow out there in London in, you know, writing things by hand and going from door to door and trying to figure out where individuals were getting their water, and then taking that handle off the pump. Another curiosity of epidemiologists is we all try very hard to get to London, go to the pump, and get our picture taken in front of the pump. There's a John Snow Society. He is who we are, so we're very proud of John. But anyway, fascinating stories, particularly if you are a lover of history. And I won't go through these slides right now. Once again, they will be available to you, but they just highlight what you read in Chapter 1. You'll recognize these figures and tables, and there's John and a picture from his book. So epidemiology is a tool for providing the basis for which prevention programs can be developed efficiently and effectively. And our ultimate goal is to improve the control of disease and maintain the public's health through prevention and treatment. And it's time for another break. Questions. Let's do questions first. Or do you want to do questions in 5 minutes? Any questions? Okay. Go think of some questions and come back, and we'll immerse ourselves in a case study.
Well, I wasn't here later in the evening. Yeah. So I don't know about that.
Started that.
Could have it, and it could not be picked up on the or, you know, sometimes it's just a screen that shows that you have this predisposition.
Right.
Yeah.
So far, so good. How about you? I have to say about that one.
There was good medications that I
That's what you're tricking me. That's what you're doing. Oh, okay. But that's what you said. Well, just the first week. And then,
everyone knows what they're going on. This is fun. I think it's difficult to know everything, but the more you know, the more you know.
I think we're doing
everything like research on the patients the day before and oh yeah. Like I hate reading. I don't get. I don't
my apartment building. Way up on the bridge. Yeah. No. Wow. No, oh, yeah. Where is that? Yeah, sure. Behind,
Oh, no. No, the only reason I'm asking, I want to try to get my staff.
Try to get home. We had the red route, the green route, the blue route, and like they were on schedule. Yeah. Oh, you have this one. Yeah. That and that's really cool.
Okay, just as a reminder, begin to initiate exercise 1. Thank you, that you'll find in D2L. It's cryptosporidiosis in Georgia. It's a case study. Provides you objectives of the exercise, a story, places where you can jot down your answers. Once again, that's not due for a bit of time, but just go ahead and at least make sure that you can find it. Take quiz number 1. It's not graded. Remember, you only have 15 minutes to take it, and then you'll be timed out. So get yourself ready before you hit the button. Many of you, or most of you, have submitted the introduction of yourself to the discussion board. If you haven't done that, go ahead and do that. That will help us remember who you are throughout the semester. You've got 2 chapters to read for next week, chapters 2 and 3 in epidemiology. And then I would like for you to jot down or put in your mind 2 or 3 items from the chapters that you would like to hear a little bit further discussion on, that you have some questions, so that you can contribute to our activities here during the time. And next class is same day, same time, Wednesday, September 2nd, 1 p.m. And this is this is 116. I'm sorry. There you go. There's a typo for you. 116. Lamb 116. So passed out and in front of you is an epidemiology case study. Incidence, prevalence, and disease surveillance, historical trends, and the epidemiology of tuberculosis. And this is for something that you can work in groups. You can work on it yourself. Take the time to go through, and you'll be learning some new terminology. You'll be learning how to calculate some rates and how to determine rate percent change between years, and test yourself on how you think about raw numbers versus population-based numbers. Now, I'm just going to start off a little bit with, on the first page, there is a graph that does not really copy very well, but I think that you can at least see the line. It's not straight. It's not going straight up. It's not going straight down. It's not going straight across the page. And I think that the point here is things are changing. There was an increase in TB cases from the mid-1980s to 1992, and it's just not apparent from the information that you have here. I mean, you could potentially guess to your best ability what might be happening, but I alluded to it earlier today. That was when we began seeing increase in AIDS epidemic, and it had a significant effect also on the burden of disease from TB. So that's potentially one reason why you begin to see those slip in cases. And then also around that time, the public health infrastructure for TB surveillance, treatment, and care was really beginning to become very, very thin in the United States. We thought that, well, we've got this under control, things are fine, we'll put our resources somewhere else. So there was actually a sort of a public health economic influence. You know, let your guard down, and what are you going to see but cases beginning to go out of proportion. So I'm going to stop there, and I'm going to allow you all to decide how best you would like to approach this case study. And this is sort of a practice case study so that you'll be able to complete that first exercise effectively, which is also a case study. And if you have any questions, raise your hand, blurt out your questions, whatever, that's fine. Yes?
I have a question. On the previous slide, there was something that said, or like the functions were descriptive data, observation, and then is it truth or transference? Are those specific orders, or are they just outlines? Wouldn't you do your observations before your data?
Right. There was no order to that. No 1, 2, or 3. Okay. Great question.
Thank you.
Sure.
Yeah, of course. Exactly, that we don't have much of that. Exactly.
And on the next page, I kind of went through this earlier. We actually show what group of people
Well, HIV was discovered in like 1981. The transfer, oh, yeah. I got it.
What did y'all think that question was?
But they also say there was at that particular time they had all these like houses that like San Francisco and New York, Brisbane.
And what was the other?
Everything at that point was I don't know if that has really anything to do with TV.
Yeah, I don't have questions that within that group. So let's say if the male 45 to 64 had actually like 300,000 people, but only like 2,700, but the female 24 to 40, yeah, that's 40, like that's
So, yeah.
The question is, like, pattern change over I think it's a little bit confusing, like what type of are you actually do that? I think that
and that's let's assume that that is where
yeah.
doesn't really
Yes.
I'm thinking.
I worked from 2003 for
We got you, girl.
Exact calculation. There's no exact.
So, we're thinking of doing
Yeah.
Yeah. And people, that's an anecdotal survey, like, even if they're doing yeah. Maybe we keep going. Yeah.
Brett is age, but I don't know that it's you don't know why. Right. I don't know what you're saying. Right, that's just doing the thing. Yeah.
Oh, wait.
You're saying.
That formula is used for.
Population times 100,000, right? Yeah. Okay. Yeah. So let's just look at incidence because they were population. You want to do the population? Yeah.
Female.
So anyway, the 45 to 65 males is 17%, 25 to 44 is 16%. Now, if you combine the females with the and the switches, take from this population to that population. So I think we're going to get to that question because one demographic is the male, but if you just do an age group. You know what I'm saying? Do you understand? Look, like, so, all right, what he was saying is like, we look at it and like, obviously, this is the total population here.
Just to remind my work like that, but I'm just trying to.
And like, 16%. Female population here is higher here. So it includes population there. Does that last like that.
It's a word. It's good.
I'm trying to be like, agreeable.
Which is great. Everyone's like, this is the biggest yeah. With you. With you.
Okay, it's 4.9.
I got the that I got. So initially I was thinking 6:30. I think 25 is I think I'm over there later to get to the okay, so we kind of like that's how I and then she corrected it. Yeah. We got a margin.
Are we talking about me? What we talking about?
I
was like my first word call.
Yes. That's when you want to.
Are you going to the line?
Yes.
Yes.
Okay, that's fine. Okay. You can wait for now.
I don't think age is all the factor. Developing TV, that's just the data. I mean, people that are below that, male, are not in that category. It's not like the outliers, just like the top and bottom now. When they graduate from that place, they don't all of a sudden their risk is huge. For the people that graduate into that, their risk don't all of a sudden increase. And just because they turn 45, I don't think
what if you only have like 150-year-olds in that population? Because you look at
yeah, because it doesn't say how many were.
Yeah, you need to know how many people were in this age group. 1.4. Yeah, that was my answer. Yeah. No, because you don't know the population.
I got 0.9 for.
Are you comfortable with that?
I wrote
oh, so within, yes.
And my guy said that.
I mean, I'm thinking, I'm here to learn.
Yeah, I'm like, well,
you think age is part of the factor? I mean, age is definitely a risk factor. Especially transmitted diseases or Alzheimer's, stuff like that.
They actually don't have a higher rate.
What you get for the second? Yep, that's how I got
I had a whole, like, population was just 15,789, and I divided that number by this. Well, I was just making sure it wasn't a trick question, so I was like, what number, like, it looks like I was there, but I just wanted to work it out. And that's when we were also talking about, we want to combine the males and females,
Oh.
But, I mean, I may have, like, missed, I mean, I'm not sure if that has, there should be close. So I just didn't.
Oh, right.
Yeah.
I got you 22. Are you done?
all of this is just math. QA is based on the drivers and the cases reported.
So we on the next page?
No, I brought my calculator. Shows you how long.
Sorry, let me start at the bottom. Or do you just want everybody knows how to use that.
Well, it depends on I did a couple. So then are you guys saying that
this should be the case. The people who have it where they're actively linked. And that's what I was thinking, because the male 65 ones are older, they have like their population is lower. So like the cases affect, like they had 1,500 cases, but their population is lower and affects at a greater rate. The male 55 and older, their population is lower because we're thinking males 45, their population 37. So they have half the population. So it can affect them in a rear.
No, I think it should be.
That's what I'm thinking.
Right in the middle.
Better magic show.
Yeah, she mentioned they're older.
They could be more susceptible.
What I was thinking now, looking back at what the we just got there, we just talking about the difference between like in so that they have been exposed to assessment and after that. Well, here, or do you think this is showing these numbers include them when they were
Yeah. So it was down to 4.
pretty good. Spread and then on the grade but also and talk you know, if we see there's awareness of it, maybe the higher
So that's totally different.
I just wonder if we weren't actually. No, actually moving up as they go. It was for.
Oh, yeah. Above the level of the
But that's a good
thing.
Okay.
That blew my mind.
Like they were looking at the definitely one of the factors in it. I don't think so what happens is my understanding is if you do my
I'm not sure how. But you shouldn't be included. Yeah, you would. Like all of the screening factors, so I'm not sure how you're doing your screening, so
How do you guys feel about equipment for okay, question to mail sex. I
don't know why. That's what I'm here. If you have really low disease, like your incidence of getting active TB is at 89%. Yeah. So don't get like diabetes.
I'm wondering too, like thinking about the population here, where you know, there are people with that might be a reason why it's
so maybe they had it.
Well, through that, and you know, people who are older, if maybe they're having a hard time.
We're not looking at the same population. No, we just a snapshot. They probably had it.
We're still going to shoot down to 7, but I mean, if we had more data, we would go through our point. But I think we're supposed to like.
But then, you know, just that people may have more barriers to actually getting to the outbreak if they're rural.
I'm sure that's true. Older people, they have.
So, immunocompromised.
And then that's kind of just going back to the question because influence like how we're looking at control takes. Like, are we talking about like all TB, like active and latent? Because we like it, but we care about the active basis. So what is this study looking at? Is it looking at all TB periods? Is it looking at people who are just fraudulent because they might have been exposed through the BCG vaccine, but they don't have no active or latent TB? That's just like how I'm looking at it from technical aspect, but it's things I'm excited to do.
So we were wondering, TV that they're talking about in the study, is latent or is active?
You know, that's how it was.
But I think there are discussions. That's kind of they respond terribly to the reporting and we would learn from it. I don't know. It's really, I didn't get there are unique in terms of what good question.
And what you do that they do have
right, exactly.
I was thinking about like they probably missed the 5%. That was even that theory tracked that. Okay, so I know that
you may not be finished, but I've heard a lot of interesting discussions and questions, and oh my gosh, I don't have the right data to give a precise answer, and what type of TV, and a little bit of frustration. So let's sort of refocus, and what were some of the concerns or some of the spots that you weren't able to agree upon as a group? Go ahead.
Not that we weren't able to agree because we get along very well and we love each other. I think that for me personally, it's always just a fear of, should we be taking it at face value, or are you going to just try to trip us up and you get So I think
sometimes I'm just not creative enough to trip people.
So I think that's where thinking and possibly overthinking an answer.
Okay, but that's kind of a good approach. Yeah, sort of always be a little bit suspicious. That's fine. Anything else?
Question 2B, I think I'm still not really sure about if when you're talking about risk, you're talking about greatest number of cases or highest incidence.
Okay. So question 2 is only using table 1.
Right, okay.
Yeah. And so does that mean that males 44 to 65 years of age are at great at risk? Not necessarily, right? Because as you point out, the information in table 1 is only count.
Right.
And that's only half of the information that you need. You always need a numerator and a denominator.
We assume that the denominator was the same.
I see. Okay. But yeah. So good question, and not necessarily. And you were only getting count, so you could not determine risk with just the count.
The risk is related to incidence.
It is. Yes. I saw another hand.
Yes. Oh, I also don't know if I was, like she said, like looking into it too much, but also wouldn't it matter if, because it doesn't tell you if people in the table are Hispanic or non-Hispanic, because wouldn't ethnicity take a role into their greatest risk factor?
And if you have the data to stratify your data to look at that question, that would be great.
Okay.
But yeah, we don't the data aren't here, at least within this case study. But sure, I'm glad that you were all thinking of what other variables could be associated with the pattern of disease. Okay. Anything else that you'd love to get the answer to before I'm sorry.
Are you gonna have the answer? I'm a little neurotic. Are you gonna tell us?
Sorry. I was like, oh, make sure I'm right. Are you doing it right? All right. Okay. So we've gotten to that point where we will now go through the answer. Wanted to get those other items that were consuming your brain. Okay, so let's see. All right. We sort of did question one, and I heard that you folks were talking about some of the other things that could affect the pattern of that graph, and that's great. So question 2. In 2007, which group had the greatest number of TB cases? Males, yes, 45 to 64-year-old males had the greatest number of cases, according to Table 1, which was for 2007. Does this mean that males 44 to 65 years of age are at greatest risk for developing TB? And we discussed that you cannot assess risk with just counts or just with your numerator data. It doesn't give you the whole picture, okay? So then you have a new formula for you that you'll see again. It's a formula that is used repeatedly in epidemiology, estimating the risk of developing a disease. And so you are looking at the number of new cases in your numerator, and then the population at risk. So you've got this population, and then your new cases are flipping into your numerator, and then you numerator is also multiplied by 100,000. That's arbitrary. You could do 10,000. You could do 100. It's just a way to sort of standardize the data as one might view it in the MMWR or the publications from CDC. So in question 3, let's see, you are now calculating the case rate per 100,000 using the number of new cases and the U.S. population estimates for each of those years from 2000 to 2007. And the first in 2000, 5.8. Who can continue down the table for me?
5.6.
Okay.
5.1, 4.9, 4.8, 4.4, 4.4.
Okay. Yeah, for 2006, 4.6. Okay, let's see. Describe the trend in TB incidence rates over time, and you're just using the data that you have in Table 2. Okay, and it's decreasing from 5.8 per 100,000 to 4.4 per 100,000. Okay, who picked out the typo?
Oh, yeah.
Okay, good. Typo, is that where the typo is?
I think it's in the next one.
It's in the, okay. Yeah, in question 4, so that should have been the example, 2007, the less than 5-year-old. Actually, females too. Boy, that really was a bad typo. 2.3. Okay.
No, it's supposed to be males. That's a typo as well.
Yes. Okay, so for Table 3, incident rate per 100,000, we see the less than 5. Oh, yeah, right. That's less than 5 males. That should be males, not female. 2.3, and then what are the rates below that?
0.7, 0.89, 4.2, 3.2, 6.0, 4.2, 7.4, 3.3, 9.4, 4.5.
Okay, perfect. Which group has the highest incidence rate of TB in 2007? Males 65 years and older have the highest incident rate in 2007 at 9.4 per 100,000. Why do you think this age group has the highest TB case rate or incidence of TB?
Immunocompromised.
Mm-hmm.
And then because of the males.
They could be immunocompromised. They could have been infected with TB when they were younger, and we're just picking up cases now because of their immune system changing, and the TB is now progressing to true disease. They could be newly infected. They just may be newly infected. Any other thoughts? Yes.
I was wondering why there was such a discrepancy between males and females of the same age. So females 65 and older have a much lower incidence rate.
What do you folks think?
I think it has a lot to do just the fact that it's already been proven like the correlation between HIV and tuberculosis. During that time period, there was a larger number of males with HIV compared to women. I think that correlation goes hand in hand.
Okay.
There's a pretty big discrepancy in population sizes for males and females of that generation because males tend to die earlier. So I think that probably was
Okay.
And also the idea that maybe some are in nursing homes or more clustered together.
We talked about barriers to access with older people actually getting to medical care. They have transportation issues. They're not going to.
It's a web of causation. There is so much that can be involved in terms of these different patterns and disease burdens. And so it's not easy to come up with the right answer. Otherwise, we wouldn't be having these discussions. But thank you for continuing to think broadly. We'd like to hear from everyone because you all have, with your different backgrounds and experiences, you can contribute greatly to these discussions. Okay, let's see. Is your answer for question 5A different from your answer for question 2A? Okay, yes it is, and why?
I think it's basically what we just discussed in part D, different scenarios and situations.
Okay, what else?
Population tables is different, so that may
Remember in for 2A, we were dealing with the crude numbers only, the numerator only, and then we were given some additional information for question 5, providing us with the denominator. And so we had the total population at risk that allowed us to gain information on rate or risk of developing a disease. Okay, and so then you have a table 4, tuberculosis cases, case rates per 100,000 population, deaths and death rates in percent change in the United States, and this is by year from 1953 to 2007. And we have described the change in TB case incidence rate presented in Table 4.
They steadily decrease for morbidity and mortality.
see a decrease. Do you see, does it continually decrease?
Yes, overall, so it's 0.3 increase.
And about what time are you seeing increases? So once again, we're using these data tables and we're looking for patterns, we're looking for changes, and at the same time, we are asking ourselves, why are we seeing these, why aren't we seeing these changes? Okay, let's see. Where are we? So you've got the rates for 1997, 1978, and 1979. And, oh, sorry, what is the TB mortality rate persist change between 1977 and 1978? Okay, so the TB death rate decreased by approximately 70%. Okay. What is the TB death rate percent change between 78 and 79? -0.31. What was that? -0.31. Did you?
I did it right. I'm sorry.
Did you multiply by 100?
Yeah. I'm sorry. Yeah, there's no.
About 31%.
31%. Okay, yes. And so the TB death rate decreased by approximately 31%. In your numerator, you have 0.9, subtract 1.3, multiply by 100, divide by 1.3. Okay, what are the possible reasons there was such a large difference between the rates for these years?
Could it be because TB was kind of active again? We're going through the same late phase and just, death is not really active.
And I want you to take away the fact that these could be real changes or they could be artifacts of the data, okay? When data are reported, mistakes can be made, and so we always want to question any data that we see. A real change might be a result in a change in the population, a change in treatment. For this to occur in a one-year period of 30% change, you're probably going to question that seems high. It's not falling into the pattern that we're seeing as we compare prior years. Oh dear, someone has raised a hand. There's Fred, let me put you on. Fred, you raised your hand, hello.
Hey, table 4 on note number 2 explains what the difference might be.
Okay, and go ahead and read that for us, table 4.
The large decrease in death rate in 1979 occurred because late effects of tuberculosis, e.g. bronchiolitis or fibrosis and pleurisy with diffusion, without mention of cause, are no longer included in tuberculosis deaths.
There you go. That's a great catch. And so those are other types of changes that have an effect on data that we collect. For example, when you go to, are admitted into the hospital or you're seen for outpatient care, every one of your diagnoses is coded with ICD codes, for example. And over the years, there have been modifications to the ICD coding. And so as soon as you get a modification, you then have to sort of control for those changes, which has been very hard. And that's when you might see small blips. But very good. Okay, and all right, where are we? Is there? Are we up? What question are we on? Did we finish? Okay, we have. Who's got the answer for question 10? Yeah. 30%, yes. And this means that 30% of these nursing home residents were exposed to TB at some point in their lives. Some may be new or recent infections, and some may be old infections. And so we're capturing the prevalence of TB in that nursing home. And then question 11 asks us about the incident rate of TB infection during the next year. Let's see, the incident rate of TB infection during the 1-year period would be 5 over 70. That's approximately 7%, since all of the 70 residents who were tested during the 1-year period had an initial negative skin test in the prior July, and so we can assume that the 5 individuals are new cases, and so that's what your 5 over 70 is. And so very good. Successful completion of case study. Thank you very much for your time and attention, and I look forward to spending some minutes with you.
Okay. For our education.
Yes. Sure. With confidence, you're fine.